Welcome to the Gastro Girl podcast. We bring together patients, experts, and health advocates who are all here to help you optimize your health. Here's your host, Jacqueline Gaulin.
Hey everyone, we're here with a special episode. This is brought to you by Ardelyx. We're going to talk about IBS-C, but this is a fascinating podcast episode because we are here with the Princess of Poop and the Queen of Colons, Christina Hanson, who's a family nurse practitioner at South Denver Gastroenterology in Denver, Colorado, and Kimberly Kearns, who is a nurse practitioner that specializes in adult gastroenterology for Duly Health and Care in Hoffman Estates, Illinois. And these ladies have 30 years of butts and guts experience. So we have the best of the best here today, ladies and gentlemen. So we're going to jump right in. And what I love about this is we're talking to nurse practitioners who have a really vital role on the care team. And it's great to get their perspective today. So let's start for those of you who may not know what IBS-C is, the causes, risk factors, just the kind of basic 101. So I'll let you kind of take over, Princess of Poop.
Yeah, I mean, thank you. That's I just feel very, very royal with those names. So thank you. Yeah, between Kim and I, we both have been practicing for, a little over 15, little over 16 years in gastroenterology as nurse practitioners. So it's always fantastic to get together with Kim, and just want to thank you, Jackie, for having us on today for this podcast. So irritable bowel syndrome, it is an extremely common referral, if not one of the most common referrals for us to get as gastroenterology nurse practitioners. Probably 30% of our referrals. And honestly, I think statistically the seventh leading diagnosis that come into primary care. So there's about 4.5 million people in the United States that are dealing with irritable bowel syndrome. And many of them younger generation, young adults. Irritable bowel syndrome, or IBS, is kind of the overarching umbrella, if you will, but there's certainly subtypes. And today, obviously, we'll be focusing on the subtype of IBS-C, which is constipation predominant irritable bowel syndrome. So it's classified as this disorder of gut-brain interaction. So what we formerly used to call a functional GI disorder, it's kind of had that shift to this disorder of that gut-brain. And that is one of the big pathways to this complex pathophysiology. We're going to talk a little bit about causes, but Kim and I can agree it is a chronic, it's debilitating GI condition for our patients, characterized by a multitude of symptoms: abdominal pain, bloating, distension, gas, bowel disturbances, really a broad spectrum of symptoms. And like I like to tell my patient, be validated. These symptoms are severe. While irritable bowel syndrome might not affect your lifespan, it's going to extremely severely affect your quality of life. So be validated. It's one of the most important things right out of the gate when I'm talking to my patients about irritable bowel. And again, we'll talk about how we empower our patients to be able to claim that diagnosis, because a lot of times these patients will go for years. Either it's hard to talk about, so they won't approach, finally approach a provider for diagnosis, but then, a lot of times they don't get a firm diagnosis. So, or they don't feel validated. They're constantly worried about their symptoms, that it's something more serious, when it is a serious quality of life affecting, but it's not an underlying organic disease. However, they don't get that firm diagnosis. So a lot of times they feel like they're kind of floating out there in the world for a long time before they get that, and they just don't get validated. So again, irritable bowel with constipation, it's a subtype of that overarching umbrella of irritable bowel. It's one of the biggest causes of what we call absenteeism from work, just because they're having to deal with these chronic symptoms, and certainly a substantial burden to, healthcare resources as well. So we talked a little bit about this idea of these patients not seeking care, but unfortunately, over 50% of patients with IBS actually remain undiagnosed. So again, it's a huge issue.
What could cause IBS-C, or what are some of the risk factors that we should be aware of?
Yeah. So I'll take a little bit more time and kind of go over some of the causes. So we know the symptoms in the setting of IBS can be related to any combination of various causes. So there's disturbances in motility, decrease in colonic contractions, for instance, in the setting of IBS-C. There's changes in water imbalances. there's this idea of increased what we call intestinal permeability. So just the lining of our intestines, we can get this kind of widening of these usually tight junctions. And when that widening occurs, more toxins and bacteria actually can be absorbed, can get into the the submucosa, where they cause what's called a visceral hypersensitivity. So we get this inflammatory reaction kind of under the lining of the intestine, if you will. And when there's nerve fibers that are nearby, obviously this inflammatory process activates that, which causes the pain that we have with our IBS, and that pain, like I tell my patient, that's the pain that leads my patients in and out of the ER. So again, be validated, but that's this word called visceral hypersensitivity. And I think
like when we feel like we're in like 8 months pregnant, right?
Exactly, that bloating and that
yes.
pain that we get. And sometimes it's just that pain without that bloating, but that 9 months pregnant is what we hear our patients talking about all the time. And there's like it's a legit pathway. That's literally something that's occurring because of this increased permeability. So again, there is something going on. A lot of times patients think, well, I feel like, is this just in my head? No, there are a whole host of different things that are going on. And, we're not really sure, what causes so many things in medicine. The pathophysiology certainly is complex. There's this thoughts that there's environmental and then our own host factors, early life stressors, we think have something to do with it.
So many factors.
Triggers, anxiety, depression, stress, sometimes food intolerances. We think that maybe, early antibiotics early in life, alterations in the gut microbiome, right? The gut microbiome is a huge area of research right now, right? We're looking at how the changes in our flora, normal bacteria, are triggering and driving all sorts of diseases, throughout our body. But we definitely think there's something to that when it comes to irritable bowel syndrome. So it's also well established that there's a pathway of this disconnect between the brain and the gut. So again, extremely complex, multiple variables, multiple things happening in concert with each other when it comes to irritable bowel.
So Christina, I think that you've laid out such a great platform of like the understanding why we're having this conversation today, right? It's so common for us in gastroenterology. The number one reason that you and I see patients, right? Just the recognition from the get-go, name the baby, call it what it is, right? And we recognize that it is such a multifactorial and faceted condition, right? So how do I think as a patient, how do we get to that diagnosis, considering most patients suffer for such a long time? Christina, what's the average amount of time that a patient says, I've been dealing with these symptoms for how long before they come in and see you?
Oh, it's several years. It's several years at minimum, for sure.
Right. 100%. So how do we get that diagnosis, Christina? I know you're the expert at this. I love hearing you tell about this. So
yeah, so it really is honestly primarily based on particular clinical symptoms. And obviously we want to make sure we're ruling out any really obvious anatomic, physical abnormalities. And it really shouldn't be this idea of, well, it's a diagnosis of exclusion. I'm sure a lot of patients that are listening at some point have said, well, this needs to be a diagnosis of exclusion. They've gone to different providers. They haven't been given a firm diagnosis of IBS, right? Call it what it is, name the baby. And so they don't feel empowered. And so they're not satisfied with their treatment. Off they go again for 5 years before they feel comfortable maybe revisiting another provider. And again, well, we need to do all this workup to make sure it's not something else. But actually it's no longer considered that. There's really this shift in thinking that we should really be calling this or looking at this as a positive diagnosis of IBS. So based on, looking at, a certain complex of symptoms with really no alarm symptoms and minimal testing. So a positive diagnosis of IBS can be based off the use of the symptoms that we call the Rome-4 criteria, making sure you're getting a good medical history, physical exam, obviously, evaluating for alarm symptoms, but really, we can be confident and data shows 98% confidence of a primary diagnosis of IBS when using the Rome criteria and ruling out alarm symptoms. So let's first talk about making a confident diagnosis with first and foremost using the Rome-4 criteria. So literally, Kim and I know this, literally a group of experts came together in Rome in the 1990s, and they came up with various criteria for different functional GI conditions, including irritable bowel. So for irritable bowel in particular, we talked about this earlier, that abdominal pain, that is the cardinal symptom. So a patient needs to have recurrent abdominal pain at least one day out of the week for the past 3 months that's associated with at least 2 of the following criteria. So abdominal pain associated with 1 related to defecation, abdominal pain related to change in frequency of stool, or change in the form or the appearance of the stool. So that is really kind of the Rome criterion when we're talking about these patients. And it's pretty obvious. These patients have been suffering from these symptoms, for years, by the time they get into us. So definitely having frequent symptoms throughout the week, throughout the month, and throughout the years. But you want to make sure that abdominal pain, because that's really what separates irritable bowel with constipation from something like chronic idiopathic constipation, or colonic inertia, slow moving colon. If you haven't gone for 7, 8, 9, 10 days in a row, you're going to feel really bloated. You're going to feel kind of stuffed and that pressure. But that's different than this abdominal pain that these patients with irritable bowel experience. Okay. So Kim, when do you feel like you're thinking your patient should be coming in and talking with a healthcare provider? And then I think we can kind of talk about some of the diagnostic testing that we would look for in a patient presenting with chronic constipation that we've got in the back of our mind. I'm thinking this might be IBS.
Sure. Well, again, thank you for laying out the platform. And the other thing I think for the listeners too, is that when we talk about this positive diagnostic strategy, I think that patients also need to feel comfortable with the way that we now as providers are moving forward with making this diagnosis, right? It's no longer this diagnosis of exclusion where you need a CAT scan, you need a colonoscopy. It's very interesting sometimes when I see some of these patients who, you're right, Christina, have seen a provider, they've ordered a bunch of tests, maybe they don't get to that diagnosis of irritable bowel syndrome. Then they come in to see me and I say, I don't need to order any tests, right? I can tell you with almost 90, as you just said, 97% certainty, right?
Mm-hmm.
This is irritable bowel syndrome without doing one test on you. And it's almost like they're like, no, you have to do a test, right? Like, do something for me. Right?
Well, this is such an important point because as a patient, you don't want to hear a diagnosis of exclusion. You want to know definitively what you have, and all those tests are even more stressful. So that doesn't help your symptoms.
Exactly.
100%. And not only is it important for providers like ourselves, nurse practitioners, physician assistants, even those in primary care, it's important for our patients to hear how we have shifted the paradigm, how we are now looking at this from a completely different perspective. And we don't have to do this gamut of tests any longer, right?
Yeah.
That's so amazing for patients. I'm so glad we're doing this today. And I want to talk about what's the patient's role in this positive diagnosis. Like, how can we as patients help to get this positive diagnosis?
Well, and I know Christina kind of threw it in my way. Like, when do we see the provider, right? So when do we see the provider? And then let's also address this question of like, what is the patient role in that? There are also some non-classic symptoms of IBS that we commonly call alarm features, right? So alarm features, which I'd like to point out, because I think this is so important for listeners and even us as providers, right? So this is, of course, not an exclusive list, right? But some of the things that definitely we want to make sure. So if there is any bleeding when there's bowel movement, that's not attributed to like a recognized or diagnosed already hemorrhoid, right? So if there's any bleeding with bowel activity or bleeding that's going on, you need to see a provider, right? If, of course, there's any unintentional weight loss is a pause moment where that's like, maybe we need to dive in a bit deeper, right? A patient has an underlying history of anemia that we're not certain of. Now, we're talking more about constipation here today. So I'd like to talk about that pain component. Sometimes when there's like pain that's just out of proportion, that's severe, that's progressively getting worse, that's, again, something that you need to kind of come in, see one of us as well. And more from a diarrhea perspective, when patients start having what we call nocturnal bowel movements, or they're having bowel movements that are uncontrollable, that they can't actually make it to the bathroom in time, or waking up in the middle of the night out of their sleep, these are things that need further evaluation. Now, some things that patients might not think about is that when you carry an underlying history of a family history of colorectal cancer, that's a pause point. You need to see a provider, right? That puts you in a different category, right? Yeah. If you've got a family history of inflammatory bowel disease, or even if you have a family history of celiac disease. So we hope by like giving you this information, right? These are like your stopping points where like, you know what? I have to go see a provider. This is when I need to go see the princess of poop or the queen of colons to get things checked out, because it's not matching up with this positive diagnostic strategy that they're talking about here, right? But your question before that you started with is, what's the patient's role in the positive diagnostic strategy? I think it's interesting because I think that it really has to start to be more readily accepted readily accepted that you're going to go in, and Christina's going to go through some more of the actual tests that we do, right? To kind of use this positive diagnostic strategy, because it's not nothing per se, but it's very limited, right? A very limited amount. And I think the patients just have to like embrace that and say, I feel comfortable with this understanding of the positive diagnostic strategy. And I actually explain this now to all of my patients. I say, I am utilizing a positive diagnostic strategy to move through your diagnosis here of the irritable bowel syndrome with constipation predominance. These are kind of my criteria. This is where you meet those. You're not meeting any of these alarm features. This is now how we move forward, right?
Oh,
Christina,
I love that. It makes so much sense as a patient, and it's accessible. Like it's understandable, and it's almost gives you a sigh of relief that I mean, no one wants to find out they have something, but if you know that something's wrong and you want a diagnosis, you want to know exactly what it is so you can treat it properly.
Absolutely. And I think one of the things too, Kim, is, we as providers, we like our guidelines, right? We like our societies for different specialties, whether or not patients understand that or buy into that or even care. We certainly do when there's updated guidelines. And the American College of Gastroenterology, American Gastroenterology Association here in America and United States, both came out with recent updated guidelines on the diagnosis and management of irritable bowel syndrome, which includes obviously constipation predominant, IBS. So these are and they support this positive diagnostic strategy and endorse it. So I think it also helps our patients when we're confident, and even to know that society guidelines are recommending this shift, that we no longer approach irritable bowel as a diagnosis of exclusion. Because in the end, when you use the Rome criteria with ruling out and considering alarm features with really minimal diagnostic testing, you can get that patient diagnosed earlier and treated quicker. So that idea of not spinning around for years, looking at different providers, if we can be confident in that, we're going to get these people diagnosed, identified, and on therapy quicker.
And that's what patients want. They don't want to be on this vicious cycle. And some of them give up and they just struggle on their own, buying one product after another over the counter, and they're miserable, unfortunately.
Absolutely. Or they get put on things over and over again, and not, because they don't have a provider who's maybe confident. So I think, at minimum for all subtypes of irritable bowel, it's certainly reasonable to just have some real basic blood work. And they often all come in maybe after an annual exam, or they've had this done with their primary care, but maybe a basic blood count, some chemistries, look at their liver and kidney function, maybe an updated thyroid. Thyroid changes can certainly cause bowel changes. At just basic lab work. If we have a patient who meets criteria for age-appropriate colorectal cancer screening and they haven't had a colonoscopy before, obviously colonoscopy. And now remember, 45 is the new 50. We should be starting colonoscopy for just the general screening population at the age of 45, depending family history, that could be earlier, et cetera. There is recommendation because of the bloating factor to still check for celiac disease, which is obviously the true gluten allergy, to gluten being the protein in wheat. So in addition to some basic lab work, checking for celiac disease. If you have a patient with very severe or refractory constipation, if they're really, really straining with stools, this may need further physiologic testing, or what we call anorectal physiology testing, manometry, function testing. There could be pelvic floor dysfunction. So something going on in the pelvic floor that's creating this refractory constipation. Could they have IBS with constipation and a pelvic floor issue? Certainly. But that would be the one other type of testing in this subpopulation that you might want to consider. But basic lab work, plus minus if there's some thought for pelvic floor dysfunction, and that's honestly about it.
And in terms of the patient, I know it's embarrassing to talk about, but what do you have for tips for patients who may be afraid to talk to their doctor? Do they feel more comfortable with the nurse practitioners? Is that something that you've noticed, or what can patients be prepared to talk about and not feel embarrassed about?
Sure. And I think, the element here and, all providers in gastroenterology, and especially when it comes to irritable bowel syndrome, and this is why we joke from the get-go, right? When we say that we have close to 30 years experience of butts and guts, right? That we're the self-proclaimed princess of poop. As soon as I sit in a patient with a room and I think, like we're going to start to have a discussion about bowel habits, it's uncomfortable, right? But I think from the minute I walk in, I try and break down some of these barriers and allow the patient, I do call myself the self-proclaimed princess of poop or queen of colons. And instantly, I think that kind of changes the dynamic between myself and the patient, right? To really be able to open up and have a great discussion about what their GI system is like. No one likes to talk about bloating. No one likes to talk about flatulence. No one likes to talk about, the pooping or not pooping, right? So I think the more that you create, like I like to call it the safe space, the more you create the safe space. And I think the more that the patients give us information, because I'll tell you, 99.9% of the time, it's not about me talking. It's about the patient talking. And they tell me the answer. Patients always, when I kind of open up the door and I just ask them questions, they tell me the answer. And before I even do anything, I'm able to actually come up with a diagnosis just by listening.
One of the things that I try to say is, hey, this is my job. I do this all day long, every day. The more details, the better, because they start to talk and then they feel, I can't believe I have to talk. I can't believe you have to. No. Give it to me. The more details, the better, because then I can help you better. So, be detailed, use eye contact, practice what we call this active listening, using open-ended questions. Like Kim said, let them go, let them talk, using open-ended questions, maybe clarifying and paraphrasing, because again, anytime, doesn't matter what kind of conversation you're on your first date, if you clarify and paraphrase that active listening, that person's going to respond to you. So being empathetic, like I said earlier, validate them. Hey, this stuff's legit. This for real. These are my patients that are heading into the ER, are on the floor in pain. So identifying and validating feelings, let them be a little emotional about it, right? They have a right to be. So certainly demonstrating empathy is certainly a huge piece of that patient provider relationship, and really letting them understand that there are a lot of things out there in the toolbox, both pharmacologic and non-pharmacologic and dietary. So making sure at those beginning stages that they know that there's a lot of things. We're going to start with this. I'm going to recommend this based on your agreement. But guess what? If it's not meeting your expectation, because there's a difference between response in symptom and adequate response. So kind of talking about those expectations. What is your patient hoping for? What would be a really good adequate response for them? So understanding their perspective, reviewing those expectations, and then developing that mutual treatment plan.
Yeah.
So speaking, do you agree, Kim? And so in terms of treatment, like what are the options? Like if someone comes, you give them the diagnosis, like what can we expect?
I mean, you just opened up the box of tools that I have,
I know, I can't wait.
So, and I think for the, Christine, you make a really good point. And I just want to point out too, like for all of course, I know that this is geared way towards, like patients, right? So if you don't feel like your provider is listening, that's part of what this is too, is that patients don't feel heard. So if you're able to be prepared, make sure that if you don't feel like you're being heard, it is okay to tell the provider, hey, I have a few more things that I'd like to say. Or also understand you may get through the first few issues and then may need to come back for a secondary appointment, and it may take multiple steps in order to get through that. So don't get frustrated, but also just kind of as Christina was talking about, like the expectation, there has to be a little expectation. I have 30-minute appointments. Christina, how long are your appointments? Not
just
30
the same.
minutes.
Yep.
30 minutes. Sorry.
Oh, wow. And how much is like with a gastroenterologist? It's shorter, unfortunately, right? Sometimes
I think every practice varies.
Different.
Varies, yep.
100%. But I always have 30 minutes with the patients. And that's because I think Christina and I do a lot of functional work, but it's a lot about listening. So again, I think from a patient perspective, make sure you're armed with your questions. Make sure you're, if you don't feel like you're being heard, please ask, say, I don't, can we pause here? Because I don't think that you are paraphrasing what I'm saying is correct. And I think that helps guide us. And please, it doesn't offend us. it helps us create your treatment plan. So you have to be an advocate for yourself as well during this process.
Great advice. And like I said, patients have a role. You're empowered. We try to do what we're doing here to give information and suggestions and tips so that patients feel empowered to not be scared or afraid to engage in a conversation. And if you're not getting the listening that you deserve, when you're not getting the attention, you absolutely have every right to ask for that.
Exactly. So to talk about that box that I have of my treatment options, right? So the very first thing is kind of like, and I'm sure Christina can do it as well. Like I kind of gauge my IBS patient, are we in a mild state? Are we in a moderate state? And what has been utilized in the past? Because as Christina said before, what's the technical definition of insanity?
Yeah.
Right.
Yes.
So as a patient, it's so important when you walk into a provider, write down everything that you've taken before. What diet have you tried? What other, medications have you tried? What was the response to those medications? And if you have all of those things ready to go, let me tell you, that makes our visit that we're talking about, how we're going to make your treatment plan, way kind of, easier to kind of utilize a different therapeutic option versus saying, okay, we're going to try treatment A. And then you leave and you're like, hold on a second. I did that 4 years ago, but I forgot to say it. The American Academy of Nurse Practitioners has an amazing tool for patients. It's called the IBS roadmap. And it actually gives the patients kind of almost like a sheet to write down. What were my previous treatments? What were my dietary changes? What did I do even from, exercise, relaxation, and what was the response? And you bring that into your visit. That's like step number one when I want to talk about treatment plan.
Can they get it on the website?
On
your website? Okay, we're going to put it in
at the American Academy of Nurse Practitioners. There is a tool. So, and it is for patients, it's
Perfect.
the patient tool. So, and this is, of course, I think an amazing tool that helps, of course, again, this treatment approach. So before I even start with that, what have you previously tried? Right. But when I look at it from a provider perspective, the very first thing is, as Christina started with, it's education is number one. That's actually a treatment, right? Teaching patient about their condition is actually a treatment. All right. So, and the next thing, of course, is also like providing reassurance. That's still a treatment, right? That's still a treatment in IBS. Like we have to recognize that. And then I move right into, lifestyle and dietary modifications. Cause that's when we look at like the algorithm, when we're talking about how we treat IBS, we look at diet and lifestyle modifications, which we're going to talk a little bit more about as we move through this paradigm. And then I start working through actual treatment or prescribed, therapies that we use for IBS-C specifically. So diet. I think, Christina, you can attest to the fact that that's the number one question we get. What can I eat? Right. So I think for myself and Christina, there's been, in regards to diet specific for IBS-C, I don't know if we have the exact, I would have to say, plan for that. But I do have to say that there's lots of data on what's called the low FODMAP diet, right? And we have to look at IBS and not just a categorical, the C portion of it, the constipation portion of it, because IBS, as Christina described, is a actual global type of symptoms, right? We've got abdominal pain, we've got bloating, constipation lies in there as well, but we really have to look at it from this more global perspective. And that's where our guidelines come from as well now. Do our treatment modalities treat a global symptoms of IBS, right? And then with the constipation element being the predominant portion of it. So with that being said, yes, there is some data that looks at, FODMAP specifically actually decreasing some of the global IBS symptoms, specifically, of course, gas and bloating. And in case we're not aware, of course, FODMAPs. So this is a specific type of food group. And I know you've done some podcasts on this before, so I'm not going to dive in too much on it because I've listened already. So of course, but we know FODMAPs can sometimes increase, GI water secretion and increase fermentation in the colon. And this, of course, produces short chain fatty acids and gas, which then leads to, of course, the distension of the colon and then triggers sometimes a lot meal-related symptoms that go along with IBS. So being on a low FODMAP diet, so eliminating that food groups, right? So it was actually, there's studies that looked at these and of course, randomized controlled trials that showed a significant reduction in global IBS symptoms. So specifically the gas and bloating. So if that happens to be your predominant symptom, sometimes I do like some layering and say, okay, let's try some modified low FODMAP, right? So the other thing is we cannot forget about our friend fiber, right? Everyone, as soon as I say fiber, they're like, oh, I've tried fiber. I'm like, but have you really tried our friend fiber? You know? So again, because we definitely don't want to repeat the same things over and over again, especially when these patients have suffered for such a long time. They're coming in to see you. This has probably been their 7th or 8th visit with somebody. But again, even society guidelines, when talking about utilization of fiber, they utilize, and recommend, utilizing fiber as actually first line therapy for IBS-C. So when it comes to IBS with constipation predominance, we know that we run and recommend soluble, not insoluble fiber, right? So, and again, that can be utilized again to treat these global IBS symptoms. So we know that there's an increase in kind of bulk and then weight of the stool, which then increases some intraluminal water. And then you got increased motion in the ocean, right? So then we've got acceleration of transit time. This is exactly what I do when I'm talking to my patients, right? So, and again, they actually did a study, and this is more for chronic idiopathic constipation, but kiwi fruit.
Oh, I just did a podcast with Dr. Schoenfeld for the evidence-based GI publication for the providers, but it's such a great abstract. It was an abstract and now it's a randomized control trial, right?
Yeah. Yes, but also kiwi fruit, so is also on low FODMAP. So, a lot of times I tell my patients, hey, let's, if they're looking for a more naturalistic approach.
2 a day.
Yeah. So I tell my patients, they're like, I really want to try something diet lifestyle. So, okay, let's try this. Let's try increasing your fiber, right? We talk about kiwi fruit. It's also on low FODMAP. And again, the goal with fiber though, remember in our wonderful Western society, there's no way that we get close to what we are supposed to have in our fiber intake, but our goals are between 25 to 35 grams per day, which is a lot. Now, don't try and do this all at once, or else you're gonna be like Kim Kearns. We are not friends. You get a lot of bloat with that. So as Christina can tell you, I'll let her chime in here.
Start slow, go low, gradually increase, and focus on soluble.
You guys should need your own show.
Start slow, go low, but work your way up there. And fiber's your friend. It's not just for grandpa. It's just the youngins roll their eyes. Well, my grandpa takes Metamucil. So there's some other formulations that are lower in bloat too. So focusing.
And we're going to give a shout out to our friendly GI dietitians. If you're going hard, if you recommend a hardcore low FODMAP diet, it's not just right. You don't hand your patient a paper.
Yeah.
Recommend.
Yes. And then of course, it's kind of like my next thing, diet considerations. And to be honest with you, right, I really tell my patients, I start simple. First, for my patients with IBS-C, I really do believe that liquid intake is important, right? So I go back and how much water do you actually intake? How much liquid do you actually intake? I tell patients, of course, if we do a low FODMAP diet and they're serious, I send them to my GI dietitians because I couldn't do it without them. The other things, of course, is that I tell patients, eat real food, which is hard, but eat real food. I'm a big believer of what you put in is what you're going to get out. And part of that too is incorporating those natural, and again, as we just talked about it, soluble, right, fibers into the diet. So, and that's kind of where, I'll start. And then of course we have our osmotic laxatives and our stimulant laxatives, which are available over the counter. So, and again, even with our osmotic laxatives, right? So these are the ones that retain water in the colon, and then of course, increase colonic peristalsis again, right? And these, of course, we have conflicting data on whether our societies recommend them or not, because they work really well with constipation. But when we talk about the pain or those global symptoms of IBS, we're not meeting that all the way, right? So a lot of patients have already attempted, the over-the-counter therapies by the time they come to see me. And I'm sure patients can attest to that too. But how many times can they mix something up, drink it down, do it twice, take another pill? They're like, I don't want to manage my life that way.
Yeah.
Right.
Just plugging and chugging all day long.
Yeah, that is a great way of saying it.
It's like plugging and chugging. You feel like you're plugging and chugging all day long and you're maxing out all the, let's move on,
right.
That's not quality of life either.
So I think I take that paradigm as we talked about from the beginning. Like I look at my initial therapies, what has already been tried? Where are they in regards to my spectrum of IBS-C? Do they have a mild case? Do they have a moderate or more severe case, right? And what therapies have gone on? So again, we always start with diet and lifestyle modification, some over-the-counter therapies, but then of course we come into play our prescription-based therapies, which I think have really been a game changer for myself in clinical practice. I'm sure Christina can say the same, because a lot of these have really come around much more often since Christina and I have been in practice. So we've actually seen the evolution of the change in therapies for our IBS-C patients, because back in the day, we didn't have I think, the amount of choices that we currently have. So our FDA approved therapies, we start with our class of drug that we call the secretagogues. So exactly what they sound like is what they do. They secrete, right? So we've got a few drugs that actually secrete. So what their job mainly is to do is to increase, and again, the mechanism, it can be a little bit more specific, and we won't go into that on that podcast, but it helps to actually increase the fluid that's available into the intestinal lumen. And with that, of course, that increases motility in the GI tract, right? Increasing peristalsis. And then the theory behind that is, as Christina really talked about in the beginning, what causes IBS and that pain component. A lot of these medications we recognize help kind of tighten up some of these junctions, or even potentially, work on some of the nerve endings, that visceral hypersensitivity that Christina was talking about, to really help with the pain component. Right. Because again, remember that key element is pain. So with that, our secretagogues, we have lubiprostone, or the other name is Amitiza. And these are medications that can be taken twice a day. And it was kind of one of the first ones, I would think, that actually Tesegrad was for it. I apologize. It was one of the first ones that I know I would write when I was in clinical practice. And then we have linaclotide, which is also Linzess, which is also a pill that is taken once a day. And the dose for specifically IBS-C is 290 micrograms once a day. And again, these are our secretagogues. Our other therapy that we have is plecanatide, or Trulance, again, which is an oral medication. It's 3 milligrams once a day. And again, these are kind of our newer kids on the block. Linzess or linaclotide was approved in 2012, and I guess plecanatide was approved in 2017. So again, both times that Christina and I had already been in practice, but newer kind of therapies for these managements of this IBS-C population. Now, our newest kid on the block, which actually has its own category, right? So of course, we've got a sodium hydrogen exchanger 3 inhibitor. Ooh, fancy, right?
Totally fancy.
Woo! So we've got tenapanor, right? So that medication, of course, tenapanor, actually reduces, it's very interesting, sodium absorption from the small intestine and the colon. And this reduction of sodium actually results in an increase in intraluminal fluid. So kind of neat, almost like a reverse, right? So it's not a secretagogue, so it inhibits absorption. So this is our newest kid on the block that we have. And again, it's an oral medication, and it's 50 milligrams twice a day. And this one came out and actually was, I believe it was approved outside of the United States, in 2002. But for us, it was last year, correct, Christina?
Yeah, it's just a little over a year it's been out.
A little bit over a year it's been out. And last but not least, and to be fair and balanced, there is a 5-HT4, which is a serotonin receptor, a select serotonin receptor agonist, which is Tesegrad, which is currently no longer on the market in the United States. But that was one of our other therapies that we utilize for IBS-C. So we look at those prescription-based therapies specifically for IBS-C. These are our FDA approved, mainly, again, of course, approved for IBS-C patient population. And again, now we've got this great kind of almost, I would have to say, toolbox to utilize for our patients with IBS-C. Now, again, each of those is unique. And I think listening to the patient story is really what helps guide me as a provider in utilizing a therapy for a patient. Now, I can tell you there are no head-to-head studies that can tell a patient which one is better over another. Don't know, right? But I can tell you, that each patient who presents to me is an individual. And with their individual story is how we individually choose a therapy, right?
I'm glad you said that, because IBS, as you both said before, is so multifactorial. There's many different things going on, and every patient's different. So there's no one size fit all. What may work for you may not work for me. So this is why, to go back to what you both said, it's important to be really upfront and honest and open with your provider, so they understand where you've been, where you want to go, and what you've tried, what you didn't try, so that they can put you on the best course of action for your symptom relief. And I think this is great information for our listeners.
Yeah.
And letting them know that, hey, we're going to start here, but depending on how you respond, if you're not satisfied, if you're not responsive, we've got some other things. So not letting them kind of hang out there in the world thinking that was their only option, or they jump around for several years from provider to provider, not going in for a few years thinking there's must be nothing more. But having that discussion for that first visit, let's try this first. We've got other things. There's different pathways. if this isn't working, we're moving on. We're trying something different. So making sure that that's level set from that very beginning. That expectation is we've got other options in the toolbox.
Totally. And Christina, for some of our other patients too, that don't want, necessarily a prescription-based therapy. And I think the component we talk about with the pain element, right? And I tell patients, sometimes I have to layer things, right? Mm-hmm. We talked about these therapies, right? We talked about, lubiprostone, linaclotide, plecanatide, tenapanor, all these medications work, IBS-C, right? So they help with the constipation and the pain component. But I'll tell you, a lot of times I have to layer things, and again, not an FDA approved type of therapy, but I layer things. And specifically some of the things I love, peppermint oil, right? Yeah. And I'm sure you and we talk about this a lot, but also for my patients who are looking for a more naturalistic approach, help with pain, right? And there was actually a study that suggested peppermint oil actually offered benefits. And again, a substantially higher amount of benefit for improving abdominal pain in patients with IBS. Mm-hmm. Now, the only thing we have to be careful is that if you suffer from heartburn, this is not the medication for you, right? But if you're having pain and the other therapies are not getting you enough relief, then I might layer something else on top of that. The other category, of course, we always talk about the antispasmodics that are tried and true, have been around for a long time, right? So dicyclamine, hyoscyamine, we recognize that these actually relax the smooth muscle. So when we talked about that, the causes that Christina mentioned in the beginning, how much, those actually help with that pain component. Mm-hmm. And then last but not least, the neuromodulators, right? Yeah. Christina said in the beginning, this has now been renamed a gut-brain interaction. So if we didn't talk about the neuromodulators, this wouldn't be a discussion on IBS, now would it?
No.
Get into it, Jackie.
Yeah, right? You know it. So, and there's a strong body of evidence supporting the utilization of neuromodulators for patients with chronic, somatic, and neuropathic type pains because of that visceral sensitivity, that visceral pain, that central pain that works on what we know, I guess, as providers. And I think it's good as a patient to recognize what actually causes this pain. It's the neuroepinephrine and the serotonin receptors in your GI tract that constantly have this bidirectional pattern of talking to your brain and your gut, because these things are so interconnected. So it's a lot about recognizing what the triggers are, recognizing how to help them, and then using these neuromodulators. So specifically, and again, I know we're talking a lot about IBS-C tonight. So again, the number one, neuromodulator that's studied, of course, has been, the tricyclic antidepressant. So amitriptyline, nortriptyline. But I'll tell you, this is for my patient who is more about looser stool consistency, maybe not so much constipation predominant. But if someone has really bad pain, I am actually going to probably layer this on and then probably give them something else to help kind of work through bowel movements as well, even if they have IBS-C. Okay.
Interesting.
I've done that. But Christina, you?
Yeah, absolutely.
Yeah.
And just there's not a one size fits all. So, looking
but this is so great for patients to know because they can come with this evidence-based information that you're providing and share it with their healthcare provider. And it may prompt a more in-depth discussion for whether this could work for them.
Right. And of course, the last one I want to talk about is the SSRIs, right? So the serotonin, reuptake inhibitors. We talk about this, how it works on the serotonin receptors, right? So again, there's some conflicting data from our two societies on whether to use or whether to not use, but I'll tell you, there's a potentially more favorable side effect than our TCA, so the tricyclic antidepressants, and they increase small bowel and colonic transit time. So for someone who I think that really could use this from a constipation perspective, that may be my go-to, sometimes overusing a TCA, especially with a patient with severe underlying constipation as well.
Interesting. Well, this has been just so fascinating. You definitely need your own show, both of you. I mean, this has been fantastic. Grateful for your.
We could just keep crashing yours.
I know. That's fine. We're going to do another episode. No, really. Thank you so much. Really grateful to have you. Have a great evening, and we'll talk soon. Thank you.
Great.
Thank you.
Thanks, Kim.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.